Шановні колеги, шановні друзі,
Dear colleagues, dear friends, again, welcome everyone at our second day of the 11th webinar about improving health of women living with HIV in Ukraine. So today is Friday the 13th, but we still believe it's a wonderful day and our event is going to be as successful as it was yesterday. So the topic of our today discussion is standards of care for women living with HIV. And in the very beginning, I just wanted to remind everyone that it's going to be recorded. So if you have any problems with connections or some like internet connections or something, you will be able to watch this recording on EX platform. You can share also this link with anyone you think it's necessary to share with. So introductions, I'll start with Caroline A.B. Pop, a doctor of medicine, researcher, Infectious Diseases Department, University Hospital, Bern, Switzerland, together with Justina Kowalska, Doctor of Medicine, Doctor of Sciences, Professor of Medicine, Warsaw Medical University, and also she's a senior consultant at the Infectious Diseases Hospital from Warsaw, Poland. So together and other people, they all inspired all of us to start the series of WAVE webinars. So Caroline, Justina, we are thankful to you for that. And also with us today, Annette Harbel, Doctor of Medicine from Frankfurt, Germany. You know, she is one of the best specialists in the area of care for women. And today she is the head of WAVE, Women Against Viruses in Europe. And this is part of EX family, as you all know. And also another co-author with us is Svetlana Antoniak. You also know her very well. She's a doctor of infectious diseases, honorary doctor of Ukraine, senior researcher at HIV/AIDS clinic, Institute of Epidemiology and Infectious Diseases, named after Gromashevsky National Academy of Sciences, Ukraine, Kiev. And briefly about our agenda program, and also some more introductions. We will start with a mini lecture to talk about the group to develop care standards of care. Nikolai Topolichik is going to talk about that. Cambria and Great Britain. Then we are going to have a question and answer session. And here I would like just to remind everyone that participants are very important because we are waiting for your questions and we will do everything possible to answer your questions. And then there's going to be another mini lecture about women over 50 living with HIV, presented by Christina Mussini, Doctor of Medicine, Head of Infectious Diseases Department and Tropical Diseases, Modena, the University Clinic, and also she's a Head of Infectious Disease Chair from Italy. After that, again, we're going to have a question and answer session. Unfortunately, Christina is not going to join us today for technical reasons, but I'm sure that our other experts and co-chairs will be able to answer the questions. Also, Alla Petrivna Volocha is going to join us today, Doctor of Medicine, Professor of Pediatric Diseases and Immunology, Medical University of Ukraine, named after Shupik, wonderful specialists on HIV and pediatric infection specialists as well, and also a person I'm sure you know really well as well. And also at the end, we are going to hear about a clinical case. This is a late presentation to get care, and Marina Sira is going to present that Infectious Disease Hospital from the clinic of the Institute of Epidemiology and Infectious Diseases, named after Gromashevsky National Medical Academy of Science of Ukraine. And sorry for taking up so much time. So it's my honor to give the floor to our co-chairs for welcoming words. So Annette, if you can start, we'll be thankful.
Okay, after this long time of online meetings, still forgot to unmute myself. So first of all, Sandy, I'd like to thank you for this perfect introduction. So the time was worth taking it, and well, I just take the chance not only to welcome everyone, but to say thank you to all the people who make this workshop possible. And I think today it's extremely important to talk about standards of care, the quality of our work, how we measure it, and also aging is another important topic. And it will be more important in future as our patients are aging. Thank God they are aging. And I don't know, I have to see the recorded version. I don't know what you discussed yesterday, but I'm sure with Jürgen and the guidelines, you had a perfect day already yesterday. And so today, Friday 13th, we take our chance. I got to know today that in Italy, for example, it's a lucky day. So not all the countries are scared by this date. But my take-home message is the same in Ukraine as it is in Germany. I don't know about Switzerland, to be honest, or UK. So we learn a little bit from each other. But now we step right into the program. And I don't know who I hand over to. Sergey, as always, be my guide.
Дякую, Аннет.
Thank you, Annette. Caroline, would be wonderful to hear from you.
Thank you so much for the kind introduction, and I'm really honored to be part of this team. Since the beginning, it's a pleasure to organize this workshop, and it's not a usual workshop. I was thinking, what is so special about this workshop? It's not only PowerPoint presentations, listening, and then stop. It's about exchange. It's about seeing people's life behind disease and infection. It's about hearing stories about women living with HIV and exchanging our knowledge to get access to care and welfare for those women. And I think this makes this workshop for me so special, that we also try to be, for example, to be aware of stigma and try to measure it, or try to at least talk about it. And when I think about the topic today, it's, for me, standard of care has so much to do with seeing that limitation of access to good care. And I was thinking that this is such an important topic, as Annette said, also in regard to aging. And I'm so happy that we never run out of topics. And I'm very pleased I was not able to be there yesterday, but I'm very pleased to see you all today. And thank you for organizing, and thanks to the participants. I wish you a very good workshop. Thank you.
Дякую, Caroline.
Thank you, Caroline. Justina, you're the soul of our little team.
I think that we have a fantastic program this year, because from the guidelines we are following to a next step, which is how these guidelines are or could be implemented. And this is specifically very interesting in the settings of Ukraine, where we know that not everything is possible right now. And we also know that before war, you have achieved a very high standard of antiretroviral treatment, access and care. So as Caroline said, a great platform for exchanging knowledge and discussing how could we help the standards to be continued for the difficult times.
Дякую, Юстина.
Thank you, Justina, very much. Ms. Svetlana. Dear colleagues, wonderful colleagues, I'm very happy to welcome everyone on the 11th webinar of WAVE EX on track to improve health for women living with HIV in Ukraine. So thank you very much for finding this opportunity, finding time, because you're busy people and we have all the challenges we can think of. Still, we can get together during 2 days, 2 hours every day to talk about important topics, guidelines, and standards of care in respect to women. Traditionally, I would like to say thank you very much to the co-chair of today's meeting, to Caroline Abbey Pope, Doctor of Medicine, researcher working in the Bern University Clinic, and being a chair of head of WAVE some time ago. She inspired our webinars on track to improve health of women living with HIV in Ukraine, together with our wonderful, dedicated friend, professor of Warsaw Medical University, Justyna Kowalska, who is with us today as well. Thank you, Justyna, very much for your support, for being the head of ECE since the very first days of war. You have organized care in Poland for our IDPs from Ukraine. We will always be very thankful to Professor Fiona Malkahi, who worked in St. James Hospital in Dublin, and she was the president of EX at that time, and she supported us. In 2019, 5 years ago, the first WAVE EX webinar took place in Kiev, the next one in Lviv. So over those 5 years, it's our 11th webinar on track to improve health of women living with HIV in Ukraine. And we are having such warm and professional meetings. It is the center of stability and positive energy. A lot has happened over those times. For more than 2 years, we are in the midst of war. A lot of other things happened in our lives, but still we continue to work. And this is our support. This is our island or isle of stability and positivity. So the fact of having this opportunity to meet and to work. And also would like to welcome Annette Harbel, Doctor of Medicine, working in Frankfurt University Clinic, and today she's the head of WAVE. Annette has been dealing with HIV in women issues for many years, author of many publications, and also a member of the German AIDS Society board. And also we will hear from Cristiana Mussini. Also we'll be discussing very important issues of standards of care. So how it's supported and provided by healthcare workers and other stakeholders. And also we'll be discussing issues how to take care of women 50 plus living with HIV is also a very important issue. So we are very thankful to you, dear colleagues, for the fact that you continue to help Ukraine, and all our Ukrainian participants, thank you very much. And because still, regardless of power outages and other problems, you are trying to improve your care of our patients. Also, you are ready to initiate ART, to work with opportunistic infections, non-infectious diseases. So you take care of everything. So let us start our work. And as usual, Sergei Antonyak is going to moderate today. So he is a researcher at the Department of Infectious Diseases at the Institute of Epidemiology. Thank you. Thank you. Thank you, dear colleagues, for the warm, nice words. So, Ms. Alla Marina, if you would like to say something, you can also join in. Hello, dear colleagues. I would like to say that it's my pleasure also to be part of this professional community. Highly professional experts. I'm a pediatric infectious disease specialist. I'm working with children, but I understand that the health of children depends on health of women. So everything is interrelated. Also, it's my pleasure to be part of the team that was developing standards of care for children with HIV. So I'm honored to be part of that. And also I'm involved in developing such standards in Ukraine. And I'm trying to implement as much as possible all those very progressive and the best practices from Europe to implement them in Ukraine for Ukrainian children as well. So thank you very much again for your invitation. Happy to be here. Thank you.
Дякую, що ви сьогодні з нами.
Thank you for being with us. Thank you. Yeah, Ms. Marina. I'm very happy to welcome everyone today. And to me, it's a great honor to participate together with such high professionals. And also, I would like to thank Svetlana Antoniak, Ms. Svetlana, because she helped me with my participation. Thank you. Thank you, dear colleagues. So let us start from the first lecture. Unfortunately, Nicolette has some problems with internet due to the weather, but hopefully she will be able to come back to us after her lecture for discussion, for Q&A session. And let us start. And the first mini lecture is basically about the group panel on standards of KEX development.
Good evening. Hello to everyone. My name is Nicoleta Policek. I'm the Executive Director of the European AIDS Treatment Group, and I will be introducing the EX Standard of Care Group. I have no conflict of interest in this presentation, and I received no funding for this. I'm going to offer you a very brief outline of what EX is, just to recap, then a working definition of standard of care, and then we'll go through the activities, goals, and outcomes of the Standard of Care Working Group. And a brief summary, hope will take you some take-home messages. So the European AIDS Clinical Society, that is EACS, is a non-profit organization whose mission is to promote excellence in standards of care, but also research and education in HIV infection and all the related co-infections. The importance of EACS is also that is the active engagement in the formulation of public health policy. The overall aim of EACS and its activities is to reduce the HIV disease burden across Europe. The key activities and the main activities of the society are, as they're listed here, education, European treatment guidelines, European AIDS conference. The next one will be in Paris in 2025, and standard of care. A working definition of standard of care is a defined package of care interventions, which clearly includes screening, HIV treatment, and prophylaxis for major opportunistic infections, but also rapid initiation of antiretroviral treatment and intensified treatment adherence support for people presenting or represented to care with advanced HIV. So it's of care for people living with HIV or at risk of HIV. So more about the Standard of Care Working Group. In 2013, EACS constituted a working group whose aim was to collect and disseminate information on standard of care, including best practice, progress, and pitfalls in different European regions. The following year, in 2014, the first Standard of Care meeting took place following a decision by the EACS governing body to organize a biannual meeting on standard of care for HIV and co-infections in Europe. It was felt essential for EACS to focus on standard of care as a specific topic, and I think this is a very important point. And that is kind of related to its main activity, but also taking into consideration many different stakeholders active in the field, such as WHO, for instance, HIV in Europe, ECDC, but also the European AIDS Treatment Group, for example. There are different stakeholders involved in the Standard of Care Scientific Committee, clinicians, institutional stakeholders, and as I mentioned already, mentioning the European Institute Group, community representatives. So the indeed experience of people living with HIV is very much present and heard and acknowledged within the scientific committee. There is a wide geographical spread because EACS members are divided into 4 scientific regions: East, North, South, and West of Europe. And as you can see from the list here, those who are involved in the scientific committee are really from most countries in Europe. So what does the Standard of Care Working Group do? Well, first of all, as I kind of hinted already, it recommends the Standard of Care meetings and other policy activities of the society and make sure that they stay close to the needs of patients and caregivers. So as I already highlighted, the lived experience and the needs of the quality of life of people living with HIV is very much at the core of the activities of the Standard of Care Working Group. So for this reason, there are not only clinicians involved, but also community representatives, as I said, people living with HIV, and also many other institutional partners. All the information gathered on the current European situation would be the basis to elaborate a wider common platform for a wide European standard of care, which at the moment is still lacking or is quite patchy. When it comes to activities of the group, there are, of course, regular meetings. There are then the organization of the biannual meetings, the Standard of Care for HIV and Co-infection in Europe meetings, has as a main aim to convene not only healthcare professional clinicians from across Europe who are active in the fight against HIV and co-infection, but also different stakeholders and partners in the community. And as I have repeated this already several times, you can see how important is the voice or the voices of the community in every facet of the work of the working group. And again, amongst the activity, we should also note a collaboration with many other stakeholders and conferences and many other organizations who collaborate with the Standard of Care Working Group. As an example of the activities, I'm highlighting here a meeting which will take place soon in October 2024 in Athens. Under the theme Standards Care for All, Embracing Those Left Behind, this meeting is co-organized by Greece and Turkey. And in this way, highlighting the importance and significance of this region situated at the crossroad of Western, Central, and Eastern Europe. So it's a pivotal geographical location, but it's more than just a geographical location. This is a closed meeting which hosts around hundreds of HIV experts. Again, community representatives will be there, and institutional partners from the WHO European region. It's a day and a half meeting which has plenary sessions, but also information sharing discussion on the current situation. Again, there will be sharing best practice, but also problems and issues, providing unique opportunity to monitor progress in the care for people living with HIV throughout Europe. Another example of the activities is the ECDC European Standard of HIV Prevention and Care project. This is a 4-year project which was launched last year, the beginning of 2023. This project will reinforce the strategic objective of ECDC to support what is believed to be the development of European standards of HIV prevention and care, with great consideration for public health, clinical, and community perspectives. In summary, the overall objectives of for the project are to define standards of HIV prevention and HIV care along the care continuum pathway in terms of quality statements and measurable and auditable outcomes in Europe. To develop also a tool which then can be used to audit implementation of defined standards at national, clinical, and community level. Again, you can hear that the community is present all the time in all the activities of the group. And throughout the project, ECDC also aims to develop between 8 and 10 standards along the HIV prevention and care continuum pathway under the guidance of an advisory group consisting of clinicians, public health, and community experts. What about the objectives and strategies? Well, first of all, is to elaborate, as I have already said, a standard of care document which defines benchmarks for different areas of care and treatment according to the guidelines. It's also about identifying indicators to allow a periodic monitoring of their progress in access to testing, access to care, and the cascade of care and prevention, but also diagnosis and management of comorbidities, with a particular focus on infectious ones. Objective strategies are also focusing on identifying beforehand key parameters which could be brought forward before the standard of care for HIV and co-infection meetings. Objective strategies are also involving every single level of any activity, institutional stakeholders such as EU Commission, ECDC, as mentioned already, WHO, UNAIDS, and HIV in Europe. But again, involving also actively individuals living with HIV and community representatives. The role of the European AIDS Treatment Group, for example, is central to some of the activities in collaboration with all the stakeholders that I mentioned already. So the goals. In a nutshell, the EAC Standard of Care Working Group goal is, as I already mentioned, to collect and diffuse data on standard of care, including the progress and pitfalls in different European regions, as well as to provide a platform which aims to share this data amongst the different stakeholders, which is really a call to action with action to follow. What are the outcomes? Well, the outcomes are very much around studies, research, consultation with different stakeholders, but also taking part at conferences. And all these have really led and is leading to an increase in knowledge on the barriers and the hurdles to a sort of EU-wide standard of care. Some outcomes are also visible and relevant to the follow-up work of the group. So we have learned through the work of the group that stigma and discrimination are still a huge concern for people living with HIV in Europe. But we also have learned that by re-auditing of the hepatitis care work, we have found that there are actually some improvements. We also learned that there are fewer Ukrainian refugees living with HIV in Poland than originally expected. And also we learned, for instance, that there are multiple barriers to accessing PrEP in Central Europe. So these are, for instance, some of the areas and topics that would require really further work, but as outcomes, is a very good starting point. In summary, so we have that the EAC Standard of Care Working Group goal is, as I said, to collect and diffuse standard of care documents, documenting best practice in some countries, progress in others, or pitfalls in different European regions, so that we can find a common platform. On a regular basis, the group elaborates a standard of care document which defines benchmarks for different areas of care and treatment according to EAC guidelines. So the importance of the guidelines is really relevant throughout the work of the group. The focus, again, is to better inform HIV testing and treatment programs, standard data collection approaches and definition across the HIV continuum of care are very much needed. And if countries are willing to ensure an unbroken HIV continuum of care, this is the ultimate goal. People living with HIV need to be diagnosed promptly, and antiretroviral therapy needs to be offered to all those living with HIV. Finally, the standard of care for HIV and co-infection in Europe meetings aim to convene not only healthcare professionals and clinicians from across Europe active in the field, but also stakeholders and partners in the community. So the importance of the voices of the community is pivotal in finding a common standard of care across Europe. And this group is really facilitating this approach. Thank you very much.
Great presentation. This is a great overview what standard of care is doing. And I think it's so important that we have all the different players on board, like people living with HIV, policymakers, and different disciplines. And it's important that something can be measured and can be improved. We need to know what's going on, first of all, and we need to define how we can measure, for example, quality of life, how we can measure stigma. It's not an easy task. And I would like to ask you for your questions. Is Nicoletta here to ask questions? Yes, no.
Ні, на жаль.
Is the
Unfortunately, no, not
Okay, but
yet.
we can start the discussion. I would like to know, yeah, from your settings, what do you think about this presentation to see, to measure, for example, stigma, to see where are the problems in not getting access to care because of stigma? I would like to know, because this was a great discussion in our group where I was joining, because there's no tools to measure this, you know. It's not something you can have a scale, or you can have. Is there anybody who has who would like to say something to this topic, to get better access and not because it's stigmatizing to get healthcare?
I think we can relate to the case that was presented yesterday by Marina, an excellent case of success in treatment but failure in early diagnosis. And we discussed that even in countries with high prevalence like Ukraine, with a lot of work from NGOs and great investment and very well organized care, we still face a lot of late diagnosis. Especially it is relevant in women. Half of the population of people living with HIV in Ukraine are women. And there is not one answer, I guess. But of course, the most natural would be stigma. And actually, we can measure it with this factor, which is the prevalence of late diagnosis, and how often people are still diagnosed with HIV by diagnosing opportunistic infection. It was toxoplasmosis and CMV retinitis yesterday. I think that we are also not using the possible chances to opportunities, for example, cervical cancer and cancer screening. Jürgen mentioned yesterday, emergency room-based screening. Those are also all points in care where we could deliver testing. And also Svetlana mentioned, Antoniak mentioned yesterday that it's very important to have enough time to discuss before and after test what is happening. So women would not only be diagnosed, but also they would show in care. And the case showed yesterday was, I can't remember if she actually was, but I remember we discussed that a lot of women, especially in transmission, HIV transmission, vertical transmission, a lot of women who are affected and their babies who are affected are women who already knew about HIV and they didn't approach care. So Svetlana, maybe you could give us some insight in what could be done for these women who know about infection, but they are too afraid, too ashamed to show in care.
Thank you very much, Justina, for this question. I would like to say that very often we say, we very often talk about self-stigmatization. It's not just stigma, but self-stigma as well. And fear, especially if a woman has fear, and a fear of disclosure, for example. When doctors, healthcare workers, sometimes they might judge, like she's doing this or that. Well, I always, when I hear that, I tell them that it's us who have to improve our care, and we really need to build our relationship with that woman in such a way in order for her to want to be close to us, to be able to disclose and trust us, and for us to provide good care. It seems to me that it's very rare happens when a person totally rejects his or her diagnosis. It's just us. Maybe we do not have enough time or do not have enough skill. So to be able to explain to a woman, not even to explain, but help her perceive, or him or her perceive the diagnosis, because it's very difficult for any person, and this pertains not only to HIV infection. Okay, so it's not only about HIV. A person can behave well and behave correctly when a person understands his or her disease. But in order for the person to understand this disease, we need to have time and desire to spend that time to explain and to inform. So I think if there is that harmony or balance, then we will be able to have necessary instruments for us as healthcare workers to be able to help a woman in such a way that we could reduce those barriers. I don't think that we can overcome the barriers that we are talking about, but reducing them is quite possible. That's my opinion. And another thing. So if we do not work well enough in the very beginning, when the person is just initially tested, undergoes initial HIV testing. So if we don't work well enough in that very beginning, when a person just learned about the diagnosis, so the worst it's going to be later on, when the problem becomes chronic, so to say, and it's going to be very difficult to provide care later on, when a person, for example, reaches the quite severe stages of disease. So then we have to just work with those problems and mistakes, but we might not even have those mistakes if we do the correct things initially. And I think those are the mistakes of the system of care provision. So we need to improve that. That's my opinion. Thank you. I know some doctors, they talk about their patients. Oh, this patient, I know her. She's such a whim. I tell her, no, I don't think it. I think it's us doctors. We don't do well enough to help patients. But it's idealistic. But would be nice if we could do that. Thank you. Thank you, Svetlana. Annette, you're most welcome.
Yeah, I'd just like to say I completely agree with you, Svetlana. And you already said we know what helps women to overcome self-stigma and stigma. Maybe we don't have enough time. Maybe some other colleagues might miss the chance. And we know the impact of self-stigma and stigma on late diagnosis, effectiveness of treatment. Even vertical transmission can be affected by this. So we have to find ways to overcome this barrier. And still, getting back to the standard of care, we need to find out about the situation in the different countries across Europe. We have to define standards, and we have to define what we want to reach, and then to audit it, to measure it, and then look if there is an improvement. And if we know about our own situation, if there is an audit and we see we miss some of the goals that were set in the standards of care, we have to work harder and find tools that can help to increase, let's say, adherence and decrease the number of late diagnoses, and also look at women-specific issues. I think it's so important, our personal experience, the situation where we work in, and then see at the broader picture, the overarching principle, and define standards across Europe, the minimum, the maximum, but what do we really want to reach? And I think that is important in terms of stigma, and Nicoletta showed many other examples. And just to let you know, we are working on standards of care for antenatal screening across Europe right now, it's extremely it's really difficult to get this to talk about this quality standards and also what can we measure, what is auditable in future. But I really believe what we don't measure, if we don't have the data, we won't convince, I don't know, policy makers, healthcare providers. We need the data. We need to show what has been measured, and we need to show where we want to go and what it takes to get there. So just my comment. Thank you.
Дуже дякую, Анет. У нас є
Thank you
також
very much, Annette. Also, we have a question in our chat with regards to adherence. There are some comments here, and there is also a question consisting of several parts. So the question is, we all understand important role of adherence to treatment, and we talk about counseling, adherence counseling, and when we see virological failure, then the recommendation and the standards of care in Ukraine are to improve counseling or adherence counseling. But what does that mean? Improved or strengthened adherence counseling? And what do you think, what should be done in order to develop good adherence to treatment in our patients? Thank you. I think that's a question about instruments, about universal instruments of measurement, so something that we can use to measure, because it's true, we say increased or strengthened adherence counseling, but a lot of factors need to be taken into account why a person is non-adherent. So it seems to me EACTS has an instrument, and there are more questions, Sergey, about instruments there. Is that right? Quality assessment instruments, is that right? All right, thank you, Ms. Svetlana. Christina has joined us. Welcome, welcome. Happy to have you here. That's true. And there is another question here, related question. Do you use in your practice PROM instrument? What do you think about implementing that instrument, and whether that might help improve the communication between the doctor and the patient and understand problems better and define strategies to improve adherence? Annette?
So PROMs are really what we would say hip right now. So everyone is talking about it, and in some countries they get implemented in routine clinical care. We all know them from clinical studies. So patients have to fill out this quality of life statements and so on. And so we were discussing lately at the YIN conference, EACTS YIN conference, if it should be really used in routine everyday practice. And you know, it was divided. The auditorium was divided. Some thought well, we all think it's helpful to measure it in studies. It's mandatory, it's useful, but we were not sure if every one of us should use it at every patient visit. But maybe we should use it regularly. You know, once a year or twice a year, it might be too often, to just check if our impression is right. You know, we all think we do a best job, and our own patients are treated best overall. We know best, but we might be wrong. So to measure it, quality of life, health-related quality of life, is really crucial, and it could help us to also a little bit overcome what we think by ourselves. So maybe we are too self-assured, maybe we are not doing that well, maybe we could do better. So everything that helps to improve patients' quality of life is most welcome. So we have to get used to it, of course, but I think it's a useful tool, not for every visit, but maybe now and then we should use it regularly.
Анет, дуже дякуємо за відповідь.
And
У
Annette,
нас-
thank you very much. Thank you very much for this answer. Christina is with us. You're most welcome, Christina.
I think that it's very complicated because I'm not sure that something that is so dependent on many other factors that is not antiretroviral therapy. I mean, if you break up with your boyfriend, maybe and you love them very much, maybe your life is miserable and it's not the pill, it's not the treatment, it's not. So I think that what we should develop to look at the pros is really new instruments, looking especially at the everyday life load of women, because I think that really what makes the life of women more complicated is that they, most of the cases, are caregivers. And so maybe we could shape the care of women considering the time that they have, for example, not if they have to take up the kids from school. We usually have the appointment at the ambulatory when it's the end of the school in the morning. This is not good for women or other things, but in the way, I mean, with the idea of making the life of our people living with HIV easier, and especially of women, we should take into account also different aspects of their everyday life. While only the pros, I think that they are more general than something that really looks at their everyday life.
If I may just react, Christina, I think that's an excellent idea. I don't know if anyone ever thought about the sex and gender related things that have an impact on your quality of life. So maybe we should work and design a questionnaire, especially looking at women-specific issues, and then we could as well adapt it to our own patients. So what kind of patients do we see? What do we need? And get some experience on that. So I think that's something a take-home message for WAVE. We could think about that because that's still missing. I think most of these pros and proms are designed by men and looking at men having sex with men. So if they are especially looking at the HIV, people living with HIV. So great idea. Just wanted to comment on that. So yeah.
Ось дуже добре. Треба адаптувати.
Wonderful. Yes. And also we have to adapt that to the needs of women. And it needs to be really done because we want it to be interesting for women. What do you think, Justina?
Sorry, I couldn't find my mic. Well, I absolutely agree with Christina. She is always the one giving very practical feedback. But on the other hand, we need to find some solutions. Prompts are tools that are by design to be used by patients. So this is something that needs to be popularized among patients before they come to healthcare. Or maybe for those who are at the visit, to make sure that they would leave a clinic with an offer of a special prompt that they could fill in. Ukraine is amazing in having the access to modern tools. I know that you have many patients using applications for communication, especially in time of war. So this is a very natural way to link to them with prompts. Unfortunately, those who are not linked to care would not be using these apps. So again, we are back with the same problem. But I see a huge role of NGOs here because they work with people from communities, people who are not yet linked maybe to care, people at risk, and that's where this could be discussed. In terms of adherence, I think long acting is something that could very much help us. So we are in a very exciting times, at least me as an HIV physician, when I already thought we have all these pills and they almost not differ and there is no more art in my work. Now I can see there is some window of opportunity, and definitely if you take a shot each half a year, then adherence is less of an issue, but stigma would remain. And again, lie and not having to use pill every day is definitely going to have an amazing a positive impact on self-stigmatization. Agree with you, Svetlana. Self-stigmatization is the most difficult part, and it's the most powerful impact.
Дякую, шановні колеги.
Thank you, dear colleagues. Thank you so much. And I'm very sorry, I'm a timekeeper. So thank you, Nicoletta, very much for really wonderful lecture. So we need to move on. So what I suggest, we will hear our second mini lecture from Cristina Mussini, and it's about women 50 plus living with HIV. You're welcome.
So today I'm Cristina Mussini. I'm professor of infectious diseases at the University of Modena and Reggio Emilia, and I'm a member of the EACS governing board and a member of the IAS governing council. We are talking about women over 50 living with HIV. That is a topic that is not so well known. These are my disclosures. So what about prevention? I mean, do we really need to address prevention of HIV infection in people older than 50, and especially in women? What we can say is that the risk of having an HIV diagnosis is still there, either in male and at a lesser extent in women, even when they are older than 50. So it's something that we have to know, and it's something that we should stop talking about HIV only to young people, to students. We have also to go in this population. And especially because since they are never addressed with the prevention and with talking about the risk of acquiring infection by HIV, infection of HIV, what we see is that many times they present late. They arrive with an infection that is in an advanced situation. This is something in many is an article published in 2022 showing that in people age more than 50, you see between 50 and 64, we still have a diagnosis of HIV, and the percentages ranges, you see, from 21% in Northern America to 7% in Southern Africa, where the population is younger. But if we look at how often they present late, you see that the situation is completely different. Many of the people who are older than 50, they present late. And that's because they don't perceive themselves at risk, so they do not test. But why women over the age of 50 could be left behind? Actually, there are 4 top reasons. The first is low perception of HIV risk. That is what I was saying. The second is that managing HIV and other health issues in this population can be complicated. And then the access to services, and then stigma and discrimination. So we have to address many issues in people living with HIV who are older than 50. We have to talk about U equal U, because many times, and we have also sexual dysfunction, because many times we don't talk about sex in people older than 50, and we are absolutely wrong. We have to talk also about cancer and precancerous lesion screening, I mean, the screening that we have to do, vaccines, the problem of menopause, but also other issues that are more psychosocial, like isolation or depression or economic instability, because many times women left work, left their job because they have to take care of children, for example. Difficulties in accessing care, stigmatization, and then also partner violence that is very, very important. So we know that women often face more social problems than men. And so it depends on the social group they belong to. But for example, I can think in Italy, some migrants from, for example, Northern Africa, it's very complicated for them to be accepted as people living with HIV. I have to say that in many cases, people who come to Italy, they acquire HIV infection also at our latitude. So for them, it's more complicated to go back and say, you know, I've acquired HIV infection, because it still have this stigma that says that you are like a sex worker if you acquire HIV infection. Well, it is not like this. And it's because we do not focus on prevention when we talk to women, and especially women older than 50. As I don't like to, to put together depression and women, because I don't think that women are more depressed than men. But it's true that we have to face it when it's there. And there are some physical transformation, for example, linked to menopause, that can, in a way, lead to a change in the mood. And so it's important to consider it and also to evaluate other problems like comorbidities, but we will talk about this later. And we don't have to forget that women are, in most of the cases, caregivers. Caregivers first with children and then with older parents. When we talk about menopause in people living with HIV, we have to think that now, these are the data of the Swiss HIV cohort, that now the vast majority of women are in postmenopausal era, for example, in Italy. Why this? Because many women got infected when they were very young, they were using drugs, or they were partners of drug users, and so now they are older than 50. So we have to talk about menopause, and we know that from 2018, there was a 3-time increase in menopause women. So it's important that we talk about it, and it's not a sort of taboo that we don't talk. And also we have to know that, okay, the alert on early menopause in women living with HIV is not there anymore. It's not that all women living with HIV go to early menopause, but this paper from the Swiss HIV cohort estimates that about 10% of women living with HIV can go in menopause when they are younger than 45. So we have to ask them when they come to our ambulatory, we have to ask them if they have their period or if they need to go to a gynecologist, or the different symptoms. Why this? Because there is the possibility to treat in a way some of the symptoms and not in a systemic way, but in a topical way. And this is, for example, with the hormone therapy substitution, hormone therapy, that is very important that we prescribe it. It's very important also because in this study, it has been shown that using any kind of hormone therapy decrease the progression of intima media thickness. So it has a protective role in cardiovascular risk. And this is something that is very important to understand, and it, especially in those who have symptoms, it's important to prescribe hormone therapy to women living with HIV. Obviously, it's not only a problem of cardiovascular risk. We all know that in perimenopausal period, there is the greatest loss in bone mineral density. And this is true everywhere. These are data from South Africa, and we can see that in the total body, when they arrive in menopause, women living with HIV had a greater loss of bone mineral density compared to women not living with HIV. So it's very important that we go to the EACTS guidelines in order to see all the how to face all the different aspects that I've talked about until now. And for example, all the screening that we have, not only the screening about depression, but also mental health in general, but also that there should be a proactive screening assessment of menopausal symptoms in women living with HIV older than 40, because we have seen that 10% of them will go to early menopause. And it's very important to prescribe topical, so vaginal hormone replacement therapy, especially in those who have symptoms, because these can have a positive effect on sexual health and urogenital symptoms. And then when we are prescribing, for example, transdermal estrogen, we have to take into account the drug-drug interaction with antiretrovirals. So it's important. Then we have non-AIDS comorbidities in women. We know that we have seen in the most recent year that especially people with HIV who have been diagnosed with a higher CD4 count can reach a life expectancy, and those who did not acquire HIV infection through intravenous drug use can reach a life expectancy that is similar to that of people living without HIV. And this is more true in men than in women, because women in the general population are living longer. So it's more difficult to reach that level. But still, I mean, the progresses have been impressive. And as I said, this, women are living always longer than men, and but the difference in life expectancy is very dependent on the number of CD4 that the person living with HIV has at the diagnosis, because too many are still presenting very late. It's not only a problem of life expectancy, so a quantity of life, but also a quality of life. So what is clear now is that not only, I mean, that the life expectancy could be similar, but what is not similar is the number of years lived without comorbidities, because it's much, much shorter the life without comorbidities in a person living with HIV. And when we talk about comorbidities, they are all comorbidities. People living with HIV are at higher risk of developing all comorbidities. You can see from this tables, liver, kidney, lung, diabetes, but also cancer and cardiovascular events. So it's something that cardiovascular in this case was even protective, but similar to the, very, very low, let's say, very similar to the people living without HIV. But this number of comorbidities obviously has an impact also on mortality. And when we look at the more excess mortality in people living with HIV, we see that the impact of comorbidities is on survival is much higher in women than in men. You see that the risk of dying of the different comorbidities is much higher than in men. When we talk about non-AIDS comorbidities, we have a lot of them. You see the cardiovascular disease, for example, is twice as much as in men because non-calcified plaques are more common, but then also pulmonary hypertension, metabolic dysfunction, bone disease, neurocognitive impairment, cervical and anal cancer. So it's very important that we follow the guidelines in cancer screening. Obviously the mammography as in the general population, so every 1 or 3 years, in all women from 50 to 74 years. But the cervical pap or liquid-based cytology plus HPV genotype testing, the same frequency in all women who are older than 21. And then in women with HPV-associated dysplasia, cervix, vaginal, vulvar, we have to perform anal exam with cytology and eventually anoscopy. All these comorbidities leads our women living with HIV who are older, they can have, polypharmacy. And this is clear from the study conducted by Giovanni Guaraldi, who is in my group in Modena, showing that there is an increase with age and with the duration of HIV, not only the age, but also the duration of HIV. So when we prescribe in the elderly, we know that there is polypharmacy. We have to also do some reconciliation, drug reconciliation. We have to see if there is an indication for on-demand medicine, because many times we just prescribe antiretrovirus, but we have to consider all the other drugs that people living with HIV who are older than 50 can take. And we see if, for example, the anticholinergic burden, we have really to evaluate drug-drug interaction, and the fact that if they are sent to have a visit to some specialists, many times they do add-on, so they put one after the other, and we can have this role of reconcile all the drugs. When we talk about drugs, we have to think about also adherence, and what I said about women being caregivers is very clear in the study, always from the GEPO cohort, that is an Italian cohort of people living with HIV older than 65, showing that an undetectable viral load in women is less present than in men, because and that's why, for example, they can benefit in a way of injectable, because they forget. They have so many things to take care of. I'm joking with people living with HIV, with male, they say that they are more adherent because women, their wife, take care of their medication, which is true. If we look at, how many people are dying of HIV, these are the most recent data on the global incidence, of the disease. We see that in the last year, HIV has really scaled down. So it's, it's rare to die of HIV and also to acquire HIV. But what we have to understand is that even in countries, for example, these are data on sub-Saharan Africa, but in general, in all countries, when it's possible, for example, we are talking about, you live a very terrible situation with the war, but I know that you are struggling to maintain as high as possible the level of, taking care of people living with HIV. So it's important to have a sort of metabolic clinic that takes care of also all the comorbidities and having always the patient at the center. So in conclusion, women living with HIV are fortunately getting older worldwide. It is extremely important to consider all their different peculiarities, from the physical ones as menopause to the psychological ones, and also to the fact that older women living with HIV continue to be caregivers from their babies to their parents, and this influence their virologic suppression. And I thank you very much for your attention.
Thank you so much, Christina, for this excellent, very comprehensive talk on aging women. And I'm also thankful that you started with a comment on ignoring a sex life after 50. And I think we have so many missed opportunities because some colleagues, they don't even consider that people of a certain age are still having sex. And so this is a missed opportunity in terms of prevention, but also for early diagnosis and early start of antiretroviral treatment. So we do see missed opportunities, especially in older heterosexuals and especially in women. And we have to think that older women also have a higher risk of HIV acquisition. For example, after menopause or postmenopausal, you have a higher number of CCR5 positive receptors in the genital tract. So there are so many changes ongoing while we age, and sex specific and also gender specific issues we have to keep in mind. And so thank you again, Christina. Lots of things I could comment and ask questions, but I'll leave the floor to the other discussants. So please, are there any other comments or questions? Take your chance. Christina's on board.
Caroline, можливо, у вас?
Maybe Caroline. I would like to thank you. Please, you're welcome.
Caroline.
Caroline, yes, you're most welcome.
Thank you. Christina, thank you for that very nice talk. I was wondering, how do you address in your consultation the menopause topic? Because I think it's very important that we see that in early menopause, or too early, before 45, we need to support women with hormone replacement therapy. And it's sometimes, it's a short consultation, and to find out if she faces those symptoms, I think the rating scale would be really good, but also to be aware, because normally our women in Switzerland, they do not see the gynecologist, and they see us, but we do not have no combined clinic. But sometimes it's so important that ID physicians would send them if they have an early menopause for treatment. And I think, how do you do that? Do you ask for symptoms, or do the women talk to you if they come for their HIV medication?
In most of the cases, I think that we should be proactive, so ask. So what I usually do, I ask. But if they come, it's important to understand, because some of the symptoms can be related to menopause, like weight gain, for example, and also to antiretrovirals. So sometimes you discover that they are in menopause because you ask for weight gain. They say, oh, yes, but I went to menopause. So I think that we should be more precise and ask them about if they are on menopause, starting from, 40, something like this, to ask, are your period, are they regular? And then look at the, and trying to address them to a gynecologist, because we have a combined clinic, but only for pap smear. So we don't do so they send them to the consultation, but in most of the cases in Italy, they have to go to specific places. We don't have the combined clinic for the symptoms for menopause. And this also can increase the wellness of people, women living with HIV, if we provide them information about menopause. What we look, it's about the illness, the sickness of the menopause, like the bone quality. So we do the DEXA scan, but we don't talk to them about other stuff like, diet, exercise. I mean, we do it, but it's not systematic. So I think that it would be important that this problem can be addressed. We are trying to put a menopause clinic inside the metabolic clinics of Giovanni Guaradi. But on the other way, all our colleagues are saying, like, you can't, face a person living with HIV on a 360 degrees. I mean, it's not possible. They have to be in the system or the national health system and refer to different specialists. But I think that menopause and menopause symptoms, especially for the overlap with some side effects with the medication, should be addressed differently.
Thank you.
If I may add, I'm also proactively asking my patients, but what's funny is, I mean, in the general population, there is not much information, really serious information on menopause, and I'm often surprised when you ask for sleeping disorders or things like that. The women say, "Oh, that can be a symptom of menopause. I didn't know that."
Yeah.
So we don't, we are all not aware of these symptoms, that they can be related to menopause. And right, Christina, you say there is an overlap. So we have to look very closely before we say, "Oh, that's all menopause," and we might oversee some psychological issues or whatever, or a tuberculosis with sweating or whatever. I mean, there's a whole bunch of diagnoses that are overlapping with menopause symptoms, but we have to be aware of that, and we have to provide serious information to the women. But as I say, I'm sometimes surprised that we don't talk about menopause. We still don't talk about it in the general population, and some of my male colleagues, I'm sure they never mention it when they see their female patient. So there is a barrier to overcome still for us.
Yeah, there is a huge stigma, I think. And the stigma is even more than the stigma about period, because it's, men don't want to talk about this, and it's okay, but we should. The problem is that we should.
Yeah, it's also, I mean, it's not an attractive issue. You are getting old. You can't get pregnant anymore. So signs of aging are obvious. So it's not. It's a depressive thing to talk about.
But actually,
if you really offer information, you can do something. And I think, like you mentioned, the hormone therapy, we don't use it enough in women living with HIV. There are still some concerns also on drug-drug interaction, and it's so easy to look it up online. And as we are using more and more integrase inhibitors, we don't have a risk of relevant drug-drug interactions. So it's getting easier.
And also with the, with the life expectancy it has been prolonged so much. We spend almost the same time in menopause and as in childbearing age. So I really think that it's not something that it's there, but we don't have to talk about it.
No,
as
we should.
Talk
no,
about,
no,
yeah,
we should.
Absolutely.
We should, and we should enjoy this time of life.
Yeah, absolutely. We do. I think I'm in
do.
Formentera. I think that we do.
Okay. Good choice. Okay. Any other comments, questions?
Я хочу поблагодарить тоже Кристину.
I would like to thank Christina. Thank you very much. Thank you, Christina, and thank you all colleagues for such an interesting topic, because, years are going by, days are coming by, hours are coming by, and they are flying actually, not just going by. And that's topic that's relevant to any person, absolutely any person. No one is in the same age, stays in the same age. So I like the idea of combined clinic. What if it could be online combined clinic? So
Yes.
maybe online counseling is an important issue. Because if we cannot do it in a physical space, within a physical space, but it could be nice. But what if maybe it makes sense to provide counseling from specialists, gynecologists, knowledgeable ones who would be able to help us, infectionists, like an online counseling, online consultation. So do you think maybe that could be a way out?
Definitely, yes. Especially, yeah. I think that would be a great idea because we are not talking about a physical examination. We are talking about talking to the person. So I think that it's a very good idea. Absolutely.
And I think we need, before we start hormone therapy, we need a pap smear, we need a mammography, and we need to see the endometrium. We need an ultrasound scan. But until then, if we tick those 3 boxes, we can start. And the most part in my menopause clinic, the first consultation is only talking, and that you're right, we could do online to see the women who are eligible for hormone replacement, because it's very easy that they don't know that joint pain, for example, can be a symptom of menopause. Like Annette said, sleeping disorders, then the emotion disorders, they think they suffer from depression, but it's only the estrogen decline that is really in the first 2 years of menopause. It's really a steep decline of estrogen that causes those mental disorders. So I think we could do that online, and then we could also say you need to do those 3 exams, and for the prescription, I normally do that before. And what I wanted to mention as well, we should not forget that women stay sexual active for a long time, and the local hormones, we don't need anything to prescribe local hormones for the vagina because there's no side effect. There's very low dose hormones that can be prescribed for anybody without having a pap smear, without having a mammography. So I think those local hormones can be prescribed. And the last thing I want to mention is the HPV vaccine. It's from the FDA, it's until 45. And we find in Switzerland that it's not offered to women. If you have doses of vaccine available in your countries, you should also vaccine women who are older than 26, and it's really effective. There's new data to showing that it's effective, even if you give it later. Thank you.
And is it paid by the healthcare insurance, Caroline? Because it's not paid at this age in Germany. I'm just interested.
Yeah. In Switzerland, it depends on the model you have, but if you can add to your insurance a prevention insurance part, and if you pay a few Swiss francs per month extra, then you get it paid, yes. But you have to fill in, there's a form you can fill, and you send it to your insurance, and then they mostly say yes, 90%, if you apply for it.
Sergey, what about, sorry.
Я також додам кілька слів. Насправді,
If I may just add just a couple of words, and in fact, I would like to say that there is a virtual pediatric clinic that we use where we all pediatricians get together online to discuss difficult pediatric cases. And it seems to me it's just like our pediatric virtual online clinic. Other specialty clinics, online clinics can be created. Yes, absolutely. And then at the end would be nice to refer for mammography, for physical exam, for pap smear, to refer. And that would make the whole cycle, because just talking is good, but we have to continue with something. So we talk and then we refer for other physical things, so to say. Good idea, I think. And also I would like to add that our participants got really interested with this topic and our today's topic, and they send their questions not only in our chat but with other online methods. So another question is whether infectious disease specialist doctors prescribe estrogens transdermally in your countries on their own without gynecologists.
In my country, the gynecologist prescribe them. I have to say, we don't do it.
Yeah, the local ones I can do, but for the, just for the genital tract, but the systemic ones, which is also use the transdermal ones and maybe progesterone as a pill, the gynecologist prescribe it. I can renew this prescription, but I want them to see a specialist first, because I don't want to decide on which formulation is the best for the patient. And I think like Caroline said, there need some examinations first. I would even add an ultrasound of the carotids first before prescribing hormones, but maybe that's a little bit too critical. But what I want to say is I'm not a gynecologist. I don't know all this stuff. So let them do their work. They are the specialists, and I can then, if it's easy for the patients when they come and see me, I can renew this prescription, but that's all I offer, because I think we should all do the stuff we know best and then so work together.
I can say from a Polish experience that it is also not frequently used. In my clinic, we have this privilege that we have 2 colleagues, gynecologists, who see patients twice in a week. So the communication is good. I always suggest topical hormonal therapy. I suggest diet, exercise. But in my practice, the biggest problem is acceptance from actually from patients. There is big unrecognized stigma for menopause, self-stigma. Women are ashamed of talking about it because they see it as process of aging, which is not the case. This is staging, but not aging. So I think we should also here involve NGOs and education, the popular websites, so women are more aware and they accept these suggestions more. I always talk about the symptoms with patients. I discuss sexual health. Many of them are just not ready to talk about it. And so the barrier is not only in doctors, the barrier is in patients themselves.
Дякую.
Thank you for your answers, dear colleagues, but we really need to move on because time is coming by. I'm very sorry to discontinue this discussion, but I think we will be able to continue after the clinical case, and then we will discuss clinical case as well. So now let us have a look at the clinical case, late presentation of a woman for care in a woman who's been living with HIV for a long time. Ms. Marina.
Dear colleagues, hello to every one of you, and let me present the clinical case with regards to late presentation of a woman living with HIV for a long time. And I have no conflict of interest. And here is Anna's story. She is 48. She has a healthy daughter, 19 years old. Her husband was an injecting drug user and died 18 years ago. His HIV status is not known. Anna is HIV positive since November 2004, which is for 20 years. She was tested during pregnancy. where she lived in that region, she received PMT-CT, but did not present for care after that. Her condition worsened in October 2023. She started to complain of decreased vision in right eye, sensation of film over her eyes, weakness in her left leg, and unsteady gait. She sought medical care from her family doctor, but she never mentioned to her doctor about the HIV that was identified 20 years ago. The family doctor prescribed instrumental methods of assessment, so thoracic spine MRI was done, a lumbosacral spine MRI also was done, spiral CT of abdominal and pelvic organs with enhancement were also performed. Osteochondrosis was found, extruded intervertebral discs, hemangiomas of vertebral bodies, left scoliosis, retrospondylolisthesis L3, dolichosigma on electroneuromyography, peripheral neuropathy of lower extremities was found. On cerebral MRI, there were signs of sinusitis. Rapid HIV test as of the 31st October 2023 was positive. So she was referred to an HIV healthcare facility. The diagnosis was confirmed, although first time it was confirmed 20 years ago. And viral load, the HIV viral load was 89,000 RNA copies per ml, CD4 5 cells, and it was CMV DNA in blood identified by PCR. And as long as CMV DNA in blood supports but is not diagnostic of end organ disease. Also, she had an ophthalmologic exam and chorioretinal acute inflammation of the right eye. It was unspecified, and she was referred to the clinic at the Institute of Epidemiology and Infectious Diseases named after Gromashevsky. On the 9th of November 23, she was admitted to our clinic at Gromashevsky Institute. Her complaints were sensation of film over right eye, decreased vision in right eye, weakness in left leg, unsteady gait, retrosternal pain during swallowing, numbness in inguinal area and lower abdomen, urinary incontinence, constipation, and general weakness. From the time of complaints until admission, 1 month was lost, but basically 20 years were lost. So here's the results of test. CD4 5 cells, HIV viral load 104,000 RNA copies per ml, antibodies to treponema pallidum negative, cryptococcal antigen negative, viral hepatitis markers negative as well. On the day of admission, indirect ophthalmoscopy was done with help of fundus camera, and we can see that in the right eye, it's very difficult to visualize retinal changes as long as the inflammation spread over to the vitreous. The same day, she was examined by an ophthalmologist, and on periphery, in retinal periphery, there was an extensive lesion with multiple hemorrhages and cellular infiltration into vitreous was seen. The diagnosis is CMV chorioretinitis of the right eye. Spinal tap was done and the CSF was tested. Also PCR was done, so CMV DNA by PCR was identified, and the HIV viral load in CSF 18,700 RNA copies, in plasma 104,000 copies. Neurological exam, muscle tone in legs and arms decreased, unsteady gait, finger to nose, heel to shin test are done with intention, pelvic organs dysfunction of mixed type. Cerebral MRI with enhancement showed no focal changes and no cerebral mass. Diagnosis is the HIV infection, clinical stage 4, CMV disease. chorioretinitis of the right eye, encephalomyelopolyradiculoneuritis with pelvic organ dysfunction, oral candidiasis, esophageal candidiasis. Treatment: ganciclovir 5 milligrams per kilo every 12 hours IV. The treatment was started since the very first day of CMV diagnosis, and the prevention is TMP SMX 480 milligrams, 2 pills a day. Fluconazole was used orally, and in 10 days ART was started, TDF, 3TC, dolutegravir. The diagnosis CMV encephalitis and polyradiculomyolysis is based on clinical signs and also based on DNA, CMV DNA identification with NET testing in cerebrospinal fluid. Foscarnet is not available in Ukraine. We use ganciclovir in standard dosing IV. So we have to treat until symptoms resolve and CMV replication clears, in CSF clears. And we have to get the negative result on PCR. So PCR, DNA, CMV in CSF should be negative. And then secondary prophylaxis has to be performed. And also we have to monitor kidney function, and also we have to consider DDIs. CMV chorioretinitis diagnosis is based on a typical picture in fundus on ophthalmoscopy, during ophthalmoscopy, and also we have to look at the response to specific treatment, CMV specific treatment. And when to start ART in persons with OIs according to EX guidelines. So ART should be initiated as soon as possible within the first 2 weeks from the beginning of OI treatment. The exclusion is for TB, meningitis, and cryptococcal meningitis. This is week 4 of our CMV disease treatment. On ophthalmologic exam, cytomegalovirus chorioretinitis of the right eye, non-active form. CSF, looking at testing, CMV DNA PCR is identified. So we continued with ganciclovir IV in standard doses. This is after 7 weeks on CMV treatment. In CSF, CMV DNA PCR was identified, and the patient noted some improvement, incontinence subsided, and numbness in lower abdomen and inguinal area subsided. So continued ganciclovir IV in standard doses. And this is ophthalmoscopy. On the right eye, in periphery, there is a chorioretinal lesion of white color with unclear margins and pigment redistributed non-active form. This is after 11 weeks of CMV disease treatment. When looking at CSF, and we've done PCR, CMV DNA by PCR not identified. And also on the 14th of February, CMV DNA PCR also was not identified. This is neurological exam, and strength in legs decreased, but okay in hands. Romberg stance unsteadiness increases with eyes closed. Finger to nose test and heel to shin test not correctly done, and pelvic dysfunction of central type. And this is again scheduled ophthalmoscopy on the 15th of February 24. There are some residual changes after posterior CMV uveitis, chorioretinal scarring. And the patient was switched over to secondary prophylaxis maintenance therapy of CMV with valganciclovir 900 milligrams per day orally. And on the 29th of August 24, CD4 101 cell and viral load undetectable. So these are the key messages. So if an HIV patient with severe immune suppression has any vision complaints, it is necessary and urgently on the same day to do a fundus exam and get counseled by an eye specialist experienced in HIV. This is the prevention of necrosis of retina and blindness. And even if there are no complaints, vision complaints in such patients, still the fundus exam is mandatory. Standard CMV-specific treatment should be immediately prescribed from the moment of diagnosis, and duration of CMV encephalitis or myelitis treatment depends on presence or absence of symptoms and discontinuation of CMV replication based on negative CMV DNA PCR result in cerebrospinal fluid by NET testing. There are no recommendations regarding optimal duration of secondary prophylaxis for CMV encephalitis or myelitis, and ART initiation as early as possible is the best prevention of activation and progression of CMV disease and prevention of new end organ damage. Thank you very much for your attention.
Thank you very much for presenting yet again a very interesting and educational case. Unfortunately, again, a late presentation. And I would like to ask a little bit a parallel question to the case. What is the intake of HIV testing among the ophthalmologists? How many of them would suspect HIV basing on this fundus examination? And it's to Marina.
Дякую, Юстина, за питання.
Thank you, Justina, for this question. Thank you. Probably I will not be able to give you the exact figure or exact rates, but still in general, and maybe a few words about your project. Okay, all right. Yeah. Okay. Yes, it's interesting because in our clinic, we are running a project. We are doing it together with an ophthalmologist, an eye doctor, and she's specializes in different problems, fundal problems in patients with HIV. We have a fundus camera. I also have the skills. I've learned how to use this fundus camera. And for all patients who have CD4 less than 100 cells per ml, we do the fundus exam. And eye specialist provides counseling. If necessary, the patient is referred to a specialized eye clinic. So this retina camera, it's called this fundus camera is called retina camera. It helps us a lot, especially it was useful in the beginning of war. We didn't have access to specialists, so this camera helped us to make a diagnosis of like CMV retinitis or chorioretinitis and send it online to an eye specialist for the eye specialist to look at the picture. So actually it's not only eye specialists, but infectious disease specialists, they can use, learn how to use fundus camera and use it in their practice as a prevention of blindness. But in general, I would like to say that not more than 5 ophthalmologists know about that, but now we are developing a network of infectionists. Marina is the first infectionist or infectious disease specialist, and she is already training other infectious disease specialists who come from different other regions to come for training to learn how to use the picture of retina in direct ophthalmoscopy, and then they might send those, and they do send those pictures, those photos to the eye specialists who would be able to help. So in Kiev, we have 2 ophthalmologists like that. So, but overall about 5. So that's how we decided to work with that retina, picture of retina, and online counseling. So Marina is under this project is doing that. Sergey?
Can I just stop up and say that congratulations, it's an amazing standard of care that you introduced there. I wish I would have that well-trained doctors, and I hope we will be more interdisciplinary, because I believe this is by guidelines, the way you should treat patients who are immunocompromised. But I'm ashamed to say that in many centers in Western countries, it's not that available.
Now, if I can add something, I think that it's available, but the problem is that what is not available is the knowledge about HIV. So it's not that everybody who sees something, some alteration like a chorioretinitis, immediately thinks about HIV. So we have plenty of ophthalmologists, but the one who really refer the patient to us are not so many.
Annette, do you do this fundus examination for each patient with CD4 count below 100?
No, we don't do that anymore. And to be honest, I was just wondering out thinking, when was the last CMV case with eye manifestation I have seen? I can't remember, to be honest. So it's really a rare thing in at least in my country by now. But you are right, there are not many eye specialists who would think about HIV when they see something like that. So we have, in Frankfurt, we have 2 of them, and I don't know the number all over Germany, but they are not, they are needed, but not for CMV manifestation anymore, or it's really, it's rare, I have to say. And also congratulations that the patient recovered. I mean, that's that was really late stage diagnosis. And sometimes we have seen the table from Christina, but sometimes even today people die of AIDS, and often combined with the first diagnosis of HIV. And that means lots of missed opportunities ahead, because I'm sure they have seen physicians.
Колеги, дуже дякую за ваші коментарі.
Dear colleagues, thank you so much for your comments, and thank you for this discussion. And we are running out of time. We have more questions from chat. What I suggest, maybe briefly touch upon those questions briefly. There is a question to Caroline. Please tell us, what did you tell in Munich recently about breastfeeding, and what was the reaction from the audience? And also, Annette, please comment on breastfeeding of HIV-exposed babies, because maybe we will touch upon those questions briefly, and maybe during our next webinars, we will just be talking about breastfeeding the whole day. Caroline, Annette, you're most welcome.
Yes, it's a different topic, but it's a standard of care also to respect women's decisions. I think it's also something we should talk about, and it's something in the high resource settings or higher where we should respect this. And we know that we have good experience with women breastfeeding. My presentation was about this, and I think the reaction was, as you know, it's great. People just need to be brave and need to support women. And I think it's like having not a C-section in former times when we changed to having a normal delivery. It reminds me that we need to have this, we need experience, and we need it from other colleagues. And I think it was a great session. It was the pediatric workshop, and people were welcoming the experience, especially in terms of ART in breast milk, because doctors were still afraid, and we could show that there's a very little amount which goes into the breast milk of ART. And I think this is good news for women on ART being suppressed. And I think Annette is the specialist here. She's like a gynecologist in topic of breastfeeding.
But you know, Caroline, I think we have reached a momentum right now. You know, after years with absolutely no breastfeeding, then after your Swiss guidelines came up, more and more countries adopted it. And I think it was also a turning point when DHHS, the American guidelines, also said, okay, you can go for breastfeeding if your viral load is fully suppressed. And so right now the situation is that we do not have much experience with breastfeeding women ourselves. But when people say there is no data out there, they are lying. There are lots of data from sub-Saharan Africa, and we can take this data for serious. And we all refer to the old PROMISE study 10 years ago, but still looking at these results and with very old antiretroviral drugs, we can assume that with the newer drugs and the integrase inhibitors, we have a much better outcome in the breastfeeding women. And so we will see less infections. And I think the question was, what about the babies? So we always care about the babies and we neglect sometimes the autonomy of the woman, the mother. But I can tell you, we haven't seen one transmission through breastfeeding, and that would be, believe me, that would be published at once if there was a transmission. But it's not a zero risk. We don't even have a zero risk in prevention during pregnancy. So we never have a zero risk, but we are close to zero. And you can't prove that a risk that is very unlikely, very low unlikely risk, you can't exclude it from a clinical study. So that is somehow the problem, and people who do not want any changes in terms of breastfeeding always refer to that. Yeah, but I think we are making big efforts, and I'm, like Caroline, optimistic that breastfeeding will be no problem in future anymore, like looking back, the switch from C-section to vaginal delivery. Yeah.
Caroline, Анна, дуже вам дякуємо за ваші коментарі.
Caroline, and thank you very much for your comments. And dear colleagues, all right, what I suggest is maybe briefly about some organizational questions and final comments from every one of you. So, dear participants, I just will remind you that you can view the recording of our today's and yesterday's meeting at YouTube channel, EX YouTube channel. And also you can get the participation certificate. In order to do that, you go to the webinar website. You have to undergo a survey. It's not to assess your knowledge, it's to assess your impressions and also to look at your experience taking part in our webinars. And this is the 11th webinar, just to remind you. And we will be coming back to you with information when is our next 12th webinar and more. And dear speakers, dear presenters, thank you so much to all of you, to every one of you. Thank you for joining. And now maybe just a couple of final remarks from you for our participants. Who is ready to start? You're most welcome.
Well, Sergey, that's not easy today because it was so much content. So how can we wrap up and get some easy take-home messages? I mean, we have the standards of care, and if there is one message, it's the one we needed. So we need to formulate quality statements. We need to find indicators, things we can measure to guarantee the same standard we define across Europe, across the different countries, and also measure if we are doing better, if we fail still some goals. So I think that is something we don't talk about that often enough, but standard of care for sure, we need it, we need to improve it. also in women-specific items, like I said, antenatal care is the big one now coming up next, and then aging. I mean, aging. If we only take out menopause, we could talk about that for hours. So aging is one of the hot topics still in the field of HIV, but I think there is for sure a data gap in terms of sex and gender specific items. And I mean, menopause is really something really unique in women. So a lot of work to do for us. And yeah, and what I take home that Ukraine is much ahead of at least Germany with online consultations and this virtual stuff. We are far behind of you, I can tell you, but it's a great thing to improve this interdisciplinary team and also to close the gap where people can't attend in person. So we have the specialists online at least. So lots of things to take home, and pros and cons. This is on my to-do list for WAVE to work on something for women specific. And I could go on for hours, but I don't want to do that. I will hand over to whoever likes to be next, but not before I thank all of you, and especially you guys in Ukraine. It's really amazing what you do, even though you have some other things on the agenda well, this war has an impact on everything, and so it's really amazing that you still hold on, and it's the 11th webinar. Go on and take care of yourself. So thank you.
Thanks to everybody, and especially to the speakers. And thanks to Sergey and Svetlana for organizing this. And when we sit together again, Sergey and Svetlana, I would like, and Justina, of course, and Justina was the founder with me and Fiona. I think we should please continue in asking questions and making suggestions, the online viewers, because when you write us, we try to make the next program suitable and fitting to your demands. And I think it's so important that you stay active and send us your questions. For me, it was, as Annette said, really a broad view of women living with HIV, this workshop, because we had so many different tasks. And the best of it is it makes us really inspired to continue for the next few. And thank you. And I hand over to Justina.
Well, thanks. Not much more to say after what has been said. Again, I'm so happy that we initiated this platform of exchanging, because I feel I'm learning really a lot. And I'm learning that if the circumstances are getting really bad and you are under pressure, you can still be a high performer. And I believe you are all Ukrainians, you are the high performers. So looking already very much forward to our next, building next programs and for the workshops.
Дякую. Дякую, колеги.
Thank you, colleagues. Christina, maybe some final comments.
Yeah, no, I think that, the situation is so bad. And I think that us as clinicians should maintain our clinical competence. We should continue to exchange ideas, to exchange, our knowledge, to help people living with HIV, to help our patients, because this is our mission. I think that doctors are always in a mission of peace, because we are healing the people, we are trying to heal the people. And this is our mission. And it's great to see how you are really focusing on it despite the terrible situation. So really, you have all our support. And I think that it's amazing to see how you're focusing on the health of you and the well-being of your patients.
Дякую, Кристина.
Thank you, Christina. Thank you very much for your warm words and thank you for your expertise today. Ms. Alla?
Хочу сказати, що мені дуже приємно
I would
було.
like to say that it was a pleasure to join in and to join this community. Actually, it's for the first time that I participate in this group. I've learned a lot about women. Very interesting topic that was interesting to me is prevention of vertical transmission and breastfeeding, everything pertaining to babies and children, but not only. And maternity and child issues are closely interrelated. So thank you so much. I've received a lot of new information with regards to standards. I will try to do my best. And again, I was happy to be part of that. Thank you. Dear Marina, so let me, on behalf of both of us, what I would like to say is just from Ukrainian doctors, what they mentioned, lots of information, and it was so easily presented, easily absorbed and perceived. So I'm really grateful to all of you. Thank you, Caroline. Thank you, Justina, Annette, Christina, Alla. Thank you. Thank you very much. And we will go on, we'll continue our work and see you next time, like that. Hugs and kisses to all of you. Thank you very much. Goodbye. Goodbye.
Goodbye, take care. And hope to see you in person one day.